Hi, everyone. Good afternoon and welcome to our webinar today, this morning or this afternoon, depending where you're joining us from. Next slide, please. Again, we want to welcome you to Support and Recovery for People Aging with Serious Mental Health Conditions webinar series. This is session 1, Psychiatric Rehabilitation Philosophy and Goals to Promote Recovery for Older Adults. This webinar is sponsored by the Northeast and Caribbean Mental Health Technology Transfer Center, or MHTTC, and we're housed at Rutgers in the School of Health Professions in the Department of Psychiatric Rehabilitation and Counseling Professions. My name is Kathy Rivera, and I'm the project coordinator of this center, and I will be introducing our webinar speaker today. The MHTTC is funded by SAMHSA, the Substance Abuse and Mental Health Services Administration, to enhance the capacity of the behavioral health workforce to deliver evidence-based and promising practices to individuals with mental health conditions. We offer evidence-based practice training for serious mental health conditions, wellness and recovery for providers and people with mental health conditions, school mental health, comprehensive multi-tiered services and support, Hispanic and Latinx mental health education, and online education courses such as Wellness Matters, IMR, functional thinking, and more. As a reminder, all of our training programs, products, and services are available to you at no cost. Next slide, please. And if you're interested in staying up to date with the events and products the Northeast and Caribbean MHTTC is providing, we ask that you please sign up to receive our email communications. You can do so by scanning the QR code, and I'll also share the link in the chat later. Following this webinar, you'll be asked to complete a brief survey. We value this feedback and use it to improve our activities and inform future activities. So we thank you in advance for your participation. We also want to let you know that this webinar is being recorded and will be posted on our website within 7 days of this webinar broadcast, along with our presenter slides. At the time of this presentation, Marian Delphin Rittman served as acting Assistant Secretary for Mental Health and Substance Use at SAMHSA. The opinions expressed herein are the views of the speakers and do not reflect the official position of the Department of Health and Human Services or SAMHSA. No official support or endorsement of DHHS or SAMHSA for the opinions described in this presentation is intended or should be inferred. We encourage you to interact with our presenter during the webinar by using the chat feature. Please post any comments or questions you have in the chat, and I will collect your questions as we go and ask them of the presenter during the Q&A time toward the end of the presentation. During the webinar, our presenter may pose questions to you, so please use the chat feature to answer them. The MHTTC network is committed to using affirming, respectful, and recovery-oriented language in all of its activities and training products. We also would like to remind you of the 988 Suicide and Crisis Lifeline for people who are experiencing suicidal ideation, mental health substance use crisis, emotional distress, or if you are concerned about someone in crisis. Now let's begin our webinar. We have Dr. Michelle Zechner with us today. Dr. Zechner is an assistant professor at the Rutgers Department of Psychiatric Rehabilitation and Counseling Professions. She has been working in the areas of health, wellness, and self-care strategies for over 15 years. Her work has centered on helping people living with mental health conditions, their family members, and the staff who support them. Dr. Zechner has worked in a variety of settings, both community and patient mental health settings, nursing homes, and in-home services. In her current role, she works with a wide range of mental health professionals, providing consultation, building staff resilience, and flourishing. She also teaches students and conducts research on motivational health and wellness practices. Again, I'd like to welcome everyone, and I'll turn it over to Dr. Zechner.
Thank you so much, Kati, and thank you everyone for joining me today. I love talking about this topic. It's really a passion of mine. Just one of the things, and I imagine that all of you here are also excited and passionate about working with older adults or people aging with serious mental health conditions. So I'm delighted to have all of you here. I want to make this as interactive as we can. So I will be asking you questions and asking that you respond in the chat. so that we can have a lively discussion through chat and interactions in that way. But I welcome questions as well. So today I'm hoping that we're going to be talking a bit about the considerations about supporting people aging with serious mental health conditions, or SMHC. Also, I want to introduce the idea or refresh our memories about psychiatric rehabilitation for people aging with serious mental health conditions. I also want to define mental health recovery and offer some examples of recovery goals for people aging with serious mental health conditions. So welcome. I'm so excited that you're here. I would love to hear your name, if you'd like, your role and your location. I already see someone joining us from California. Thank you for joining us so early this morning in your time. I'm on the East Coast, so this is right before lunch for me. But if you could go ahead and just drop in sort of your name, your role, and your location in the chat. I'd love to hear from you in that way. And I see someone has already sort of said they're excited and scared, since some of the people that they serve are challenged with aging. And absolutely, I think that's why we're all here and interested in that. I see some, oh, wonderful, people from Chicago and New York, social workers. I see housing folks. I see, oh my goodness, all the way from Washington State. Awesome. I'm glad you're here. Good morning. Oklahoma, Iowa, North Carolina, Indiana. Oh, wonderful. Well, it's so great to have you all here. And someone from Philadelphia, which is not too far from where I live, and Boston. Oh, wonderful. I'm so glad you're here. Florida, Nebraska. Oh, a peer support specialist. Yay. And Illinois and North Carolina and Utah and Texas. Wow. Well, thank you all so much. I really appreciate your introductions. Ohio and Delaware County, not far either from me. And in ICM, Intensive Case Manager, Newark. Wonderful. Well, I'm so glad all of you were here. Thank you so much. And I'm hoping to give you an introduction. Maybe this is a review. Some of you, it seems like, have some knowledge and skills about older adults, and some of us are learning. I think I'm learning every day. Despite the work that I've done, I feel like we all learn. So, oh, and wonderful. Someone with the American Heart Association. Wonderful. Great. Well, welcome everyone. It's so nice to be with you today. I'd like to start out with, and I had in my mind thought I would have a poll, but we're going to do the old-fashioned unfancy poll of put in the chat, what's the age range of people you typically support? I know there's at least one school social worker here, so I'm excited about that. But do you work with people under 25, 25 to 45, 45 and up, or all of the above? I know we often get into, I teach a class in psychiatric rehabilitation and aging at Rutgers that I developed about 12 years ago. And my students all come in and they're like, yeah, I only want to work with kids. And I'm like, okay, here's the sad story about that. You will be working with children, but children often have parents, and they have grandparents and caregivers who are often 45, 50 and over. So whoever you are, wherever you are, you're likely to be working with people who are aging, and you may be aging as well. Who knows? I think we all are aging every day, and that's sort of the idea of healthy aging, which we'll talk about in a few minutes. So I'm checking out the chat. I see 18 and up, all of the above, 60 and over. Cool. Under 25, 18 to 25, 18 and up, all of the above, adult men. Interesting, 55 and over, all of the above. And we're going to talk about this idea of age sort of discrimination and cutting off of services and siloed of services. So it's very interesting that we all sort of identify very specifically the age ranges. And as a researcher, I do research, and I'm very interested in the topic of older adults and wellness as we age, particularly with mental health conditions. What we find is there's a lot of silos of care, right? So I might do a research study, and I have to say in my protocol that I'm going to recruit folks 65 and under. If I do 65 and over, then there's another special process I have to go through, because that's considered a special population. So already we're seeing some divergent issues with the age, and that's very cool. So welcome. I'm excited that we have such a great representation across the continuum. So let's talk a little bit about this topic of older adults with serious mental health conditions. And I'm trying to shift my language from who are older adults with serious mental health conditions. I'm trying to also shift that to people aging with mental health conditions. And you'll see why in a second. And when I'm talking about serious mental health conditions, I'm talking about things like schizophrenia, bipolar disorder, major depression. And usually what the people that I have worked with in my career are folks who've experienced a lot of disability or functional impairments, like difficulties in their life, whether that's managing their money, living independently, holding down a job, a lot of difficulties in a lot of different areas. These are folks particularly that receive care from the public mental health system, meaning community mental health centers, also state psychiatric hospitals. So this is, for people receiving care in this way, they likely have lived a lifetime of poverty, which we'll also talk about how that influences our aging process, and have sort of a number of challenges that they face. Now, the big one, I think, is always a little bit shocking to me. I just admit I was being ageist, but in the research that I've done, in the reading that I've done, and looking at other types of resources from SAMHSA and other, the National Institute on Aging and National Institute for Mental Health, we're starting to think that older adults, also people aging with serious mental health conditions, that category really begins at 50 and over, which is a little bit young, it seems like. But the challenge is, and we'll talk more about this in the next slide, there is such a rate of premature aging in the population. And I'll give you a quick anecdote. I was doing a health promotion intervention with a community mental health center. The folks were ranging from like 30 to 60 years old with an average age of about 50. And part of what we had to do for that intervention is we asked people to do strength tests, right? It was called Wellness for Life. It was a great health promotion intervention that combined education, peer wellness coaching, and supported physical activity together. And so part of what I had to do as the coordinator, I was like, okay, so we're all gonna, test our strength. And I had to get on the floor and do sit-ups with people because that's a measure of strength. And what I found is that people my age and younger were getting down on the floor and then they couldn't get back up. And I was like, this, I was doing this probably in 2009. And I was like really shocked at how hard it was for people. So you probably have stories like this as well, of people who are in their 40s and early 50s who are already experiencing a lot of difficulty doing things that other people not, who aren't living with a mental health condition wouldn't necessarily have such difficulty with. So let's look more specifically. The challenge with this population, I love the work and I think it's fascinating and I'm really passionate about advocating for people, and there's not a lot of research out there. There's not a lot of information out there. SAMHSA is definitely doing a great job. I want to give credit where credit is due. There are a couple of great newer reports. There was one that came out in 2021 that's in the resources of this webinar. And it talks about the estimation of the percent of people who have a serious mental health condition of 50 and over. And the estimates are about 3% of the population. And I really want to clarify that I'm not talking about necessarily people living with Alzheimer's disease or other dementia disorders. So I think that I'm really kind of in this presentation mostly focused on people living with schizophrenia, bipolar disorder, major depression, who were diagnosed in their early 20s and 30s. So that they've lived with a chronic mental health condition for many years. Now, I will say that many of that population, they may have people with mental health conditions are more likely to experience substance use. They're more likely to experience homelessness. So those risk factors actually make aging accelerate, which we're going to talk about in a second. And it can lead to some dementia. It can lead to some cognitive impairment. And the conditions themselves, schizophrenia, there's a lot of evidence that brain scans show that there is a shrinking of the brain. So we don't exactly, this is kind of a new area. We're not really 100% sure of why that is. Some people say it's long-term use of these psychotropic medications. Some people say it's related to sort of the genetic expression of schizophrenia. We don't exactly know, but I'm getting myself sidetracked here. The most common disorder that we see is major depression. So people who've lived with depression most of their life, or schizophrenia, also bipolar disorder. So I've seen a lot of folks aging with those conditions. And I will say that, we do know that people have experienced so many health conditions, and we're going to talk, that's going to be one of our themes throughout today and the coming sessions. But the level, the awareness of health conditions is raising. So there are people, despite all of the health conditions and the risk for premature death, people are living a little bit longer with serious mental health conditions. And so we do need to be able to sort of understand the population that's a little bit different. So let's talk about what normal aging is. We're all aging every single day. From the moment that we're born, we're babies, we're infants, we're aging, right? Each day, we're getting one day older. So these are normal changes that occur over our lifetime, changes in our bodies, changes in our senses, changes in cognition, and changes in our friendships and supports. Our bodies typically slow down and function differently, depending on our genes, right? Our genetic background, but it's also related to poverty. It's related to discrimination and stigma. Aging is related to stress. So all of those things kind of combine together. I do see a question. I want to stop for a second. Are people with SMI more prone to Alzheimer's? That's a great question. What I can tell you is that people with mental health conditions or SMI are prone to more cognitive difficulties. What do I mean by that? There's this fancy term, executive functioning, which is sort of like being able to make decisions, being able to focus, concentrate. Those are often problems for people who have schizophrenia, bipolar disorder, or major depression. And as we get older, it's sort of normal that we have some of these executive functioning problems. And some of the literature suggests that people are experiencing difficulties with thinking earlier. Now, is that Alzheimer's? Alzheimer's is a disease that is very specific. I have not seen any literature that suggests that there is that link and correlation. That may be true, but I have not seen any of that literature. So I would say that, the other thing about accelerated aging, it's also, I touched on it through poverty and stress. Those are things we call social determinants of health. I'm assuming that we all have heard those terms of social determinants of health, which just sort of means we used to say socioeconomic or whatever, sort of the external features to a person that shape and influence how we react and cope with our lives. The other thing I do want to include in this is trauma. And there, been a lot of discussion about trauma, and the ACEs study, the Adverse Childhood Experience study, which looked at people as they age. One piece of information I am aware of is that the perception of pain and experience of pain and management of pain is much more challenging for people who've experienced trauma. So that's something that we need to be aware of, that the perceptions of pain for people living with mental health conditions might be a little bit different than people who aren't experiencing mental health conditions, but it's something that we need to be talking about with our clients and service recipients. We've talked about some of the risks of health and functioning challenges. People are experiencing age-related conditions, and what would that be? I talked about mild cognitive impairment and thinking challenges, But I'm also thinking about things like um, diabetes, which is your risk for diabetes increase as we get older, but it's also a risk, right, of obesity and things like that. So that's a risk factor. Things like cardiovascular health conditions, emphysema, COPD, those kinds of health conditions happen in folks living with mental health conditions at younger ages. And functioning, I did a study a couple, like 2 years ago. We wrote a paper, my team and I, and we compared the physical abilities of people who were middle-aged to who had a mental health condition to people who were older adults. And what we found really was shocking. And the title of the paper, it kind of says it all, old before their time. We found that the functioning of people with mental health conditions was 20 to 30 years older. So I'm going to say that again. People who were living with mental health conditions for much of their life performed physically, strength, flexibility, endurance at levels. Let's say if someone's 45, they performed at a 65-year-old or 75-year-old. So that's something that is really important as, helpers, as supporters. Because we need to adapt our services and we need to be aware. I've been talking to a lot of housing providers over the years to say, supported housing services. It's really important that we're aware that people are going to be experiencing health challenges and functioning challenges much earlier, which makes independent living harder. Someone just asked me why. Well, I'm so glad you asked that. And it's very complicated, but the bottom line is that people are not accessing healthcare when they are, and we're going to talk a little bit more about that in a few minutes, that when they receive healthcare, they may not get the best healthcare because of provider attitudes, unfortunately, discrimination, the belief that people can't get better. So they're not getting great healthcare that addresses, preventatively some of these challenges. Also, this group, more, folks living with mental health conditions are incredibly sedentary, which means they sit a lot. I sit a lot. I work in a sedentary job, but they're saying now that sedentary behavior is actually as dangerous as smoking a pack of cigarettes a day. So we need to be aware of that. The movement really is important. And so then if you don't move, you lose muscle tone, and then you lose your abilities. Also, people are taking very sedating medications. Wow, someone just read my mind. There was a question about medications. Yes, medications are very sedating. And so people then don't feel very motivated or energized to get out and move. So it's just this complex array. And then the mental health conditions themselves for people with depression or bipolar disorder or schizophrenia. Really, the idea of these, it's called negative symptoms, or when people aren't very motivated, they don't feel enjoyment, they feel difficulty and challenges. Those become a little more common as people get older. So it's even harder for people to build up that motivation and drive and energy, or maybe even belief that they can make a difference in their health. So there's a lot of challenges, and those are things that we have to be aware of. So we could be like, you know what? I tell people every time I work with clients or consumers or service recipients, peers, whenever I talk to people, I say the best thing you could do is get up and walk, like stand up. Even if you're not healthy enough to walk, maybe you can do some arm movements, talk to your doctor, encourage our clients to be more active, because that's critical for brain health. It's critical for physical health as well. And of course, I've said sort of these sort of heavy things, but we also really, really need to know that folks are really resilient and strong. And I'm sure you've seen this in the people that you've supported as well. People have a long history of managing difficult health conditions across the decades. So they have stories, they have friends, they have experiences. They've been resourceful and successful in living their lives. They've had friends, they've had dreams, jobs, they have curiosity, and they want to, I should say that I've worked with people in nursing homes a long time ago. I worked at a nursing home with a lot of people who'd been deinstitutionalized straight from the state hospitals. This was a long time ago. So there was a lot of tardive dyskinesia and really extreme side effects from medications, which we don't see as much, but we still will see as we age. Our liver, our kidneys, they and all of our organs slow down a little bit. So we have more difficulty metabolizing medications, which means that people who are aging with mental health conditions, their medications may stop working. They may become suddenly too strong, which can have a really, difficult time with their recovery and their procedure. So let's talk about a little more this mental and physical health balance, which I think is important for all of us, regardless of our age. But it becomes even more critical as we age because our bodies are just changing so much. People are living with more chronic health conditions, as I mentioned, diabetes, cardiovascular issues, respiratory problems, metabolic disorders, thyroid, weight issues, cancer, and chronic pain. And there's just a lot of issues with the health system in terms of addressing some of these issues. Many folks have used substances in the past. Maybe they, I saw this at the hospital. Maybe some of the folks that you've worked with as well have seen this. So I consulted at a state psychiatric hospital, and I led group, I facilitated, I supported the facilitators on units. And some of the wildest things were people would get better and then they would be discharged, or they go out on a community pass and they would consume substances that they hadn't for a period of time and become very ill and sometimes overdose and sometimes pass away. So the way medications or substances are absorbed in our body changes as we get older, which is something we really need to talk to the people that we work with as well, that we are all changing. Also, there's some evidence that folks are challenged with health literacy, sort of understanding what a diagnosis, health diagnosis, or how to take a medication. If just think about some of the conditions, and if you have 3 chronic conditions and you have to take 2 medications for each condition and at different times of day, knowing and understanding all that can be really, really difficult for any of us. The other very important thing that we need to be talking about is infection, because the rates of infection in older adults goes up, particularly urinary tract infections, which have a huge impact on people. I don't know if the people that you've worked with have had that experience, but I've seen it in the nursing home, I've seen it in the community, I've seen it in the hospital, that people get a urinary tract infection, and that cognitive decline is called delirium, where it happens literally overnight. Someone is sort of doing their, living their life, and the next day they don't know where they are, they don't know what's going on, and that's really related to an infection. So if you work with someone and their cognitive abilities change extremely rapidly, you want to make sure that they get medical care immediately. It could be a stroke, it could be an infection. So anytime, I think there's some misconceptions sometimes about aging, which we're going to talk about in a second, that confusion is a normal part of aging. It's not a normal part of aging. Confusion is related to disease process. It's also related to infection. So if someone has a sudden experience of that, get to the doctor right away. Okay, so I want to hear from you. I've been talking a bit now. I'm going to take a sip of water. What do you know about people aging with serious mental health conditions that you think is important that I haven't raised yet? Please go ahead and put that in the chat. I would love to hear any additional thoughts that you have about topics or important points that should be acknowledged about people aging with mental health conditions. Don't be shy. Oh, thank you. Lack of resources. Definitely lack of resources. We're going to talk about this in a second. There's not enough geriatric psychiatry and counseling. There's a huge, the Institute of Medicine has a great report called In Whose Hands, and it talks about, so across the board, there's a lack of mental health providers for older adults, but particularly for this population, there's really very, very, very little. Also discrimination. Thank you very much. There's a lot of age discrimination and other types of discrimination. We're going to talk about that in a second. a lot of places won't accept them. And I thank you for bringing that up, because it's really, I have had one foot in, I started out in aging, I switched to mental health, and now I'm trying to have one foot in each world. And it's quite challenging because aging services don't really want people who have mental health conditions, and mental health services don't really want people who are aging. So the reality is we've got folks who fit that category. Where do they go? Um, and there's a lot of discrimination in nursing homes and in assisted living is how we call it where I live, but those kind of intermediate level of care for older people where they may get some meals or housekeeping, and it's kind of a congregate living or senior high rise. Opportunities to age in place, absolutely. People losing their non-formal supports, yes, absolutely. Trying to rebuild your formal connection or your informal connections, is really, really important for people. And it can be really daunting, if people are dying that we love, our families are dying. Provider bias, thank you. That's a great one. And also challenges integrating behavioral health care in primary care, and absolutely integrated care. We'll talk about next week, the different interventions that are really effective. Integrated care is really important, but it's very challenging to do, right? For billing codes and, practically speaking, in my state in New Jersey, it's been really hard to get everybody on the same page because the behavioral health providers are under one licensure area and regulations, and healthcare is in another. And to try to do that integrated care is really, really challenging. Stigma, absolutely stigma. Family support, leaving when folks die. Also mobility, thank you. That's a really important one as well. Those functional limitations mean that people have difficulties walking, people getting isolated. And there's so much evidence that social isolation changes our brain. It actually causes cognitive decline. So we all need friends, and especially as we get older, we need more friends. Lack of transportation, healthy food. Oh, I'm glad you brought that up. Thank you. Having and also poor dentition. I'm doing some research now looking at oral health of people living with mental health conditions, and particularly as people, I'm thinking of that program that I mentioned earlier, Wellness for Life. We had information about dentition, and I remember a guy who'd been, experienced homelessness, substance use, mental health conditions many years, and he's like, I only have 4 teeth. I don't care about my teeth. And the dentist was wonderful, and she said, you know what? We love those 4 teeth. We want those 4 teeth to last as long as possible. So dentition, like where your teeth are at and how healthy they are, that affects pain, it affects mood, ability to speak and communicate. Have you ever worked with anyone? I know I have, when I did case management in the community, who has lost a lot of weight or gained a lot of weight, and their dentures don't fit, right? Or people lose their dentures and then it's hard to pay for them. Definitely experiencing stigma. And COVID and folks with SMI, there are a few papers coming out about that. What I do recall and reading is that folks with serious mental health conditions were more likely to get COVID, and experience long COVID, which also is a challenge to thinking and cognition. Hello, I'm living it myself, having had COVID recently. And any resources, the CDC has a few resources. I would check them out. Also, I don't know for sure, but I would think that the National Institute of Mental Health may have some resources as well. And actually, my colleague and I, Joni Dolce, did a talk about long COVID. And it's up on the MHTTC website, our website as well, and using some of these rehab strategies. Oh, wow. Distance to service is really a problem. Folks lacking understanding. And wow, okay. If people show signs of aggression and gaslighting their mental health conditions, that's a really hard thing. That takes time, and relationship is what I would suggest, is building that relationship with the person. And having senior centers, wow, you guys came up with such great things. Thank you so much. I'm really excited that you're thinking about all of these things as passionately as I am. Um, and having senior centers be welcoming environments, I think, is important as well. Not having family or friends to help people find resources, absolutely. Um, and then provider bias. So we're going to talk a little bit about that. It's really, really hard. I think that's an advocacy discussion, and it's a little beyond what we're going to talk about today. But definitely, I'm going to give you some ideas and plant some ideas. I think for ourselves, we can reflect, but we're going to really have to advocate and do a better job in that to address this and raise awareness. We're going to talk a little bit more about that. People getting discharged from skilled nursing. Wow. Oh my goodness. And dumped onto mental health services. Yeah, that's really, really challenging. And in New Jersey, we've had a model program that was designed to handle mental health crises in nursing homes. And so an organization would go out and try to navigate, problem solve to prevent hospitalization and help give the nursing home supports. It's been a challenging project. And I know that the nursing homes, they don't necessarily want people who are going to cause difficulties or sometimes some nursing homes say, yes, okay, we're going to just take everyone with a mental health condition. And that really looks like trans-institutionalization, right? Where they're from a state hospital or a hospital setting or a very intensive setting, and then they go to this nursing home, which is all other folks, which is not very normalized, right? Technology. Wow, is there a comprehensive list of all of these things we're naming? No, but you're making me so inspired. I'm, considering maybe, Kati, I'm going to task you to help me remember this. I think we should put all of these points in a document that goes along with this webinar, because this is really, really rich stuff. Thank you very much, everybody, for your thoughts. I'm very grateful for that. So this is clearly a really, really bright group. And I encourage, one way to break the stigma is to encourage the providers that you work with to look at the Facts on Aging quiz. This was developed by Braidsprake and Badura. And it's not really a quiz, it's more like information, and they're true or false. So I give this to my students, and it's basically, ageist beliefs. I would encourage you to sort of play around with it. It's in the resources as well. These are all false. Actually, most people over 65 don't have Alzheimer's. Intelligence is pretty static. It doesn't decline. What changes is our ability to process information quickly. People can learn new things. That's false. Personality is pretty static. So people who are friendly and wonderful as young people are often friendly and wonderful as older people. People who are a little curmudgeonly and difficult as young people often, not always, but often are pretty curmudgeonly as they get older. If people have dementia, that can cause significant personality changes. And that's a disease process, but we're talking about normal aging here. Memory loss is a normal part of aging. It's not, actually. We may, have some word finding problems or difficulty recalling. I experience it like 20 times a day. I don't know about you, but I'm like that thing. That's normal. That's really normal. What's not normal is if we have, a conversation with someone and they ask you the same question over and over because they can't remember what you just said, which is different than anxiety, which is they're asking you the same question because they want reassurance, right? Clinical depression occurs more frequently in older than younger people. No, it's actually pretty much statistically about the same. And most people are living in nursing homes. They're not, actually. Most people, older adults are living in the community. So this is just a sample of these questions. They're kind of fun. You may want to check it out. So what are the perceptions on aging? And you all are so brilliant and passionate. You've already addressed some of these issues. So how we think about aging, I'm laughing, but I'm amazed at how wonderful you are. I'm also really sad that as a community, we think and you know, the American society doesn't place a lot of value on aging, which really influences so many elements of our life. It impacts health. So health outcomes get much worse if we experience aging. Um, we also feel terrible about ourselves. Like if someone tells you you're too old. I remember this must have happened about 10 years ago, and I was walking around when I was consulting at the state hospital in New Jersey, and one of the service recipients looked at me and was like, "Hey, grandma." I was like, "What, me?" Um, but I'm giving you a lighthearted example, but it's really, really hard when your providers, your health providers, or the people that around you are telling you that you know, you're too old to get a job, you're too old to you know, look for your dream partner, you're too old to make any, you know, difference in your life. That's really, really horrible discrimination, and it makes us question who we are and our abilities, and can cause depression. Actually, people who have experienced a lot of discrimination and ageism are more depressed. And it also shapes our cognitive health. So, meaning our ability to think and focus and concentrate is impacted if we're discriminated against. Um, and then I see another couple comments. Uh, Long-term care facilities are biased against people who are not age 55 and older. Yes, because you know of the history of putting a lot of folks from um, psychiatric hospitals into nursing homes. There's, you know, the PASSAR, I think it's called. I don't know if that's limited to this area, but basically ways to make sure that people who have mental health conditions aren't automatically put into nursing home care, which is considered a higher level of care. Rather, we look for other alternatives. And yet, if someone's under 55 and they meet the criteria of nursing home care, meaning, you know, they're not, you know, have difficulty bathing themselves or feeding themselves, or just those basic tasks of everyday living, they definitely may need that level of care. If they've had a significant stroke or other debilitating disease, that may be the level of care that they require. So also medications, let's see, I'm trying to see. Yes, the future really means that people will be taking more medication, and they may have more mental health symptoms, and it may need to be managed differently. Thank you. That's a great point. Um, Ageism and discrimination, it's so prevalent, and you all are already mentioning it. Mental health coverage, like just when we think about ageism as a structural element, right? So it's in our communities, our organizations, and society, and it really influences how we provide services. You all are bringing up some great points of discrimination of people with mental health conditions. I've also found that some mental health providers don't want to provide service to people over 65. So then there's this funny thing, like aging services don't want to serve younger people or people with mental health conditions. And sometimes mental health providers don't want to, or behavioral health providers don't want to provide services to people 65 and over because they don't believe they can change. And a lot of, like, you know, I know that there's a huge, like, as bad as the shortage in mental health services, the shortage in substance use services for people over 65 is even worse. Very limited resources. Yes, billing is a pain. I think insurance is a big issue. I think people are also, I think people in aging settings don't necessarily have the background and training in mental health. They don't know what to do and they're afraid. I think that's part of it. And in mental health, they're afraid of older adults and they have ageism and they think, you know, I don't think this person will benefit from any kind of care, which kind of goes against the idea that we're helping people a little bit. I don't know. Anyway, we also want to be aware of the isms pile up, which the fancy name intersectionality. So the impact of ageism and discrimination is likely much, much worse. There's a lot of research that's been done in this for people of color people in marginalized communities such as LGBTQ plus or non-English speakers, because they're just layers of discrimination, or that intersectionality, and gender, sexism. Women, older women may be more discriminated against than older men. So all of this adds to additional stress and discrimination and difficulties, and people, internalize that over the years, and that can be really, really difficult and part of sort of believing in oneself. Um, Self-reflection is really important, and I think self-reflection is important for ourselves to ask, is something that we're doing, is this ageist? And I encourage you, there's the person that I really love is Ashton Applewhite. I don't know if anyone of you are familiar with her, but she has a great TED Talk on ending ageism. She's got a great book called This Chair Rocks, a manifesto on aging. And I love her blog. She has a blog called Yo, Is This Ageist? And people write in anonymously, and they're sort of like give examples of, work experiences, or, something that happened on TV in a TV show. Is this ageist? And she talks about it, which I think we as a culture need to spend a little more time talking about. And we need to talk to our service recipients about this. Because I think they have internalized a lot of these ageist ideas. So I worked with a group at a different hospital. We did a wellness intervention for, I think it was 8 weeks. It had a lot of different components to it, where we looked at sexuality, we looked at physical wellness, we looked at intellectual wellness. And I remember sitting, I was co-facilitating that group on intellectual wellness, of course, because why would I not be? And I asked them, the group, it was about 10 or 15 people. They were probably an average age of about 67 or something, many in wheelchairs. And I said, do you think that you could teach old dogs new tricks? And they were like, no, you can't. I was like, wait a minute. Let's talk about that. So it's we also have to really, ask people that we're working with what they think about aging, and how to bust some of the stigma in our own selves. So yeah, people are more additional great comments in here. Hearing aids are not covered, and definitely hearing loss and vision loss are both risks for mental health conditions and cognitive decline. So great points. I'm so glad you brought that up. I want to sort of, before we move forward, just say that Ashton Applewhite had a really, really great quote. I love her so much, but she says in her TED Talk, why on earth do we stop celebrating the ability to adapt and grow as we move through life? Which I think is like, yes, like we should be, looking forward to that perspective that we gain as we age. And then she goes on to say, why should aging well mean struggling to look and move like younger versions of ourselves? So I think that's pretty good. But this idea of growth, this is where psychiatric rehabilitation comes in. I have my PhD is in psychiatric rehabilitation. I've been a firm believer and practitioner of psych rehab since about 2005. So I really, really believe that it helps and it works for people. What is it? I imagine reading the chat, I can see that a lot of folks are chatting in there, and you probably are doing much on psych rehab. And then someone asked about tracking goals. That's a great question. We're actually going to talk next week about some strategies, and goal setting is one of the strategies that we are going to talk about next week. So I hope you'll come back or tune into the webinar afterwards. Psych rehab is any strategy or programs that help people living with mental health conditions restore their abilities and move forward with their life, and programs that promote recovery, full community integration, and improved quality of life. So our challenge, which you all have we've been already talking about this, it's so siloed, all of our service providers, right? We've got aging services, we've got community mental health services, and we have physical health services, which are sort of a whole other beast. So there's just a little coordination across these avenues, which we often find ourselves in. And it's a likelihood that our clients may need services from all of these areas. Like, the area agency on agencies are great because sometimes they have things like Meals on Wheels or, transportation services, but people may need mental health services as well. And they may need some rehabilitation, like physical rehabilitation or primary care from that is affordable from, things like the FQHC, the federally qualified healthcare centers. And they're doing some interesting demonstration projects, not about this population, but trying to do that integration of care, which we've been talking about. I see. Okay, we've got a few questions. And Kati, if you wouldn't mind putting the link for the registration in the chat, that would be great. So a lens of psych rehab is really, I argue, this is my belief, my firm belief. I've been thinking about it for a while. I think psych rehab can really help us think about older adults or people aging with mental health conditions, because it's really focusing on strengths and helping them move forward with the supports that they have to have a quality of life. Recovery is the basis of psych rehab. And we're going to talk a little bit more about that later, but it's basically the actions that a person does to move beyond the symptoms of their illness and it sort of improve their health. And it comes from hope. We're going to talk a little more about that. So I'm going to leave that there. It's also about community integration, living a life that's integrated in the community, in the least restrictive and most independent community setting. I remember I had this argument, I'm sorry, I bring up a lot of my hospital experiences because they were pretty profound and shaped my thinking a lot about psych rehab and older adults. I had an argument with the psychiatrist once that I said, we need to get these people out of the hospital. They shouldn't be living on sanatorium way. And she said, well, nursing homes are no better. And I said, no, actually, having worked in nursing homes, living in a nursing home is definitely an improvement. I'd much rather live in a nursing home, which is age appropriate, which is, if you need that level of service, you need that level of service rather than a long-term stay in an inpatient setting. So thinking about it, that might mean helping people live in scattered site housing or congregate house. There's some little evidence actually that older adults with mental health conditions would rather live in congregate housing, like with roommates, with other people and supports. There was one article that was published years ago about supportive housing on that. Also helping people live that quality of life, a sense of well-being in many different areas with social supports, good housing, financial well-being, and feeling positive. The values of psych rehab. Now, these came from a mix of, SAMHSA has a great resource on recovery, which I linked to in the resources, the working definition or working statement on recovery. I'm also very fond of my colleagues, Carlos Pratt and Ken Gill, Nora Barrett, and Melissa Roberts from the Department of Psychiatric Rehabilitation, which I'm a part of. They authored a book called The Principle, sitting here, it's called Psychiatric Rehabilitation, but I really love the way they've laid out the goals, values, and principles. So that's what I'm referring to, and from this as well. It's also self-directed, meaning we try, and I know that you all try, to help people make decisions and choices for themselves about their goals, where they want to live, what they do, and how to be as independent as possible, really trying to give people as much choice and voice as possible. Also, that dignity and worth and respect for the person and who they are and what their wishes are. Also having some hope for recovery, learning, and growth. Psychiatric rehabilitation came out of occupational therapy, which was really like, how do we help people recover and move on? And then early on, it really focused on employment. Now, employment may not be a goal that many of our clients are looking for, but they may. What I really like to think about is that sort of occupational wellness, which is our clients and service recipients, our peers, they may want to be having a meaningful activity each day. And it may be something that we can support them in doing, whether that's work, or full-time, part-time, or volunteer opportunities, or just having a sense of purpose each day. Wellness, that idea of multidimensional wellness, where we are taking action each day to promote our health and well-being in all areas of one's life, social, financial, occupational, intellectual, spiritual, physical, environmental. I'm sure I'm forgetting some. We did some work, and we added the developmental wellness, meaning how do we feel about aging and aging well, and also promoting those normal roles uh, for someone, like to think of themselves not as a patient, not as a sick person, but as someone's mother, someone's daughter, someone's cousin, um, sister, worker. They may be caregiver themselves for someone else, or a friend. Any of those roles is what psych rehab is sort of saying. We want people to find who the roles that they want in the community, and we want to help people get to those roles. And then there are some guiding principles. These are overlapping. It just gives you kind of a rough idea of person-centeredness, like knowing who they are and really that person in context, which we'll talk more about in the next series next week. Also partnerships, and like partnering with the person that we're supporting, with their family member if they have them, with their other community members. Offering peer support. I'm delighted to see that there's a peer supporter here. I'm working on a project with the Academy of Peer Support in New York State. I think I've linked to that in the resources. They have a new certificate for peer supporters and older adults, which has been a lot of fun. Peer support is really, really important. And that could be paid peer support, or it could be unpaid mutual help from others living with similar lived experiences. And in the peer world, there's a lot of discussion. Should it be is a peer someone who is an older adult, or is it someone who's a peer who's a younger adult? And there's a lot of discussion that goes back and forth, but offering that choice to the person and maybe what they prefer. And those natural supports, you already are talking about the informal supports that we want to see people connecting with: neighborhood groups, faith communities, library groups, just anything that's not mental health related. Focusing on strengths, acknowledging strengths, having people really aware of what their strengths are, and using what we call a situational assessment. And that just really means focusing on what the person is coming to you with. If you're a mental health supporter and the person comes to you and they're like, I really want to make more friends, that's the area that you work with on that person. And I know that if you're in housing, and we do have some housing folks here, you may have to force some, other areas. But I give the example of this. Like, I am kind of a chaotic person in my closets. I'll be honest. Like, I need to go to Closet Messy Anonymous or something. But the state of my closets, or anyone's closets for that matter, does that really influence whether their ability to talk to people, to make friends? Not necessarily. So we really try to kind of keep a focus on the one area that the person is bringing to us, or that we work with the person on, so that we're not sort of saying overall this person is a hot mess just because they have a messy closet. Oh gosh, I hope not. And an emphasis on skills training. We'll talk a lot about that next week and some of the examples that are available. And the integration of treatment and rehabilitation. So making sure that services include prescribers and therapy and counseling, but also rehabilitation, or those groups, those actions, those strategies that we use to really help the person move forward in their lives. And we also want to make sure that it's research-based. Mental health has a very, very sad and awful history in using services that were not very effective. And I'm not going to go into all of that, except to say that it's really important that we use the best knowledge that we have to help people get better as best we can. So that was a whole lot of information, but I'd love to hear from you. What are some goals, values, or principles that you rely on in your work? If you could just place that in the in the chat, I would value it. So I'm just going to scroll back so you can see some of the goals are recovery, community integration, quality of life, the values. Oh, let's see if I can get back. Those are the principles. And so there are the values. Oh gosh, and I see I skipped over culture. Oh, forgive me. Our culture is so important to recovery because it's who we are, it's how we define ourselves, it's what we gather, our strength from. Definitely, we need to recognize and acknowledge culture. Please forgive me and my COVID brain, that oversight. Oh, someone says they use humor. I'm so glad. And yeah, housing are often and mental health issues. Yeah. And acknowledging that people are the experts on themselves. It's so important, particularly older adults, right? They've been around a while. And it's, we want to encourage because, think about it. If you've ever, been in a situation where a doctor is like, you don't know what you're doing, you need to do this, you need to do that. And what if that was all of your providers sort of saying, you're not competent, you don't know what you're doing? Eventually you're like, you're right. Like, I'm just going to let, my friend, George Bryce, who is a peer, he always says, that's stinking thinking. That's, that's the kind of thinking where we need to kick it out of our heads and say, no, you know what? We have strengths. We are empowered to do what we want with our lives. So I see that a lot. I've seen that a lot in the hospital. I've seen that in the community also, where people just become, and sometimes we call that institutionalized thinking, where it's sort of like, I'm just waiting for someone to tell me what to do because they're going to tell me what to do. So I might as well just do what they tell me to do. And that's just, that causes a lot of hopelessness. Oh my gosh, we've got some great comments. Thank you. Person-centered, partnership, flexibility, non-judgment. Yeah, and we've got some folks here who are doing some hard work. Thank you for your work. This is really important work, though, to help people move forward. Hope, absolutely, learning and growth. Yeah, really driving purpose, and having that purpose in ourselves gives us energy to go through. Actively listening. Wow, yeah. And thinking about my own parents and what I'd want them to do. Yes, and being aware of our biases. Absolutely. You may want to sort of check yourself when you meet with people. Wow, this reminds me of somebody. And that's when it's a great time to get supervision as well. Using wellness, awareness, valuing self. Thank you so much, everybody. And thank you for the kind words. Always appreciated. Always appreciated. So, okay, paying attention to this group, I think someone has made the point of, as we get older ourselves, we are more drawn maybe to this work because we can empathize. I think that could be true for some people. I also think it might be less true for other people. I don't really know. For me personally, out of college, I worked at a nursing home. I really loved working with older adults, and I think it's different for everybody. I think SAMHSA and the National Council on Aging, I think a lot of the larger regulators are starting to raise awareness. The challenge with people aging with mental health conditions is they consume a lot of resources, more than almost any other population, with a lot of chronic health conditions, a lot of difficult challenges and social determinants of health. So whether or not we want to be looking at this group, and whether or not the government, the policy makers and whatnot want to go there, I think we have to, because it's really managing people's lives, and it's a financial bottom line. Yeah. Oh, this is wonderful. All right, thank you. Some examples of psych rehab strategies. I'm just talking globally right now. We'll talk very specific programs next week, but goal setting. Someone mentioned goal setting and how to track that. And there are some great resources online about goal setting. Something I found myself drawn to, I ran illness management and recovery groups in the community and in the hospitals. I don't know if you all know what that is, but it focused on goal setting and self-management. And there are some tricks that you kind of want to think about is you can track them using SMART goal setting, specific, measurable, actionable, relatable, and time sensitive. I think SMART. But if you Google SMART goal setting, you'll see another new one that I really like is WOOP, Wish. Oh gosh, well, look up WOOP, WOOP. It's from Australia, and it's a wish, obstacle, outcome, and promise. And it's a different way to think about goal setting, and it's kind of inspiring. But what it does is it sort of says what I wish to happen is the goal, and then I sort of look at any obstacle, and I try to plan for any obstacles that might get in the way. And a lot of the coaching models kind of follow that as well. So and also with older adults, you may have to go slower. It may take a little more time. And I did find that in my experience, it takes a little longer to help people kind of zone into what they're most interested in. It might help to use visuals, and it might help to use sort of give people, a few categories to choose from to begin with, because people, again, may not be used to making their own decisions. Sadly, they may not feel empowered to make their own decisions. So and they may be experiencing some executive functioning challenges, the focusing and processing. So that might be something to consider as well. Motivational interviewing, which probably many of us know about, is a communication style designed to help people consider behaviors they want to change. That was designed for substance use. However, it's being used in health promotion, a lot of different decisions. And we're actually going to talk about a very specific decision-making tool next week. We want to focus on strengths as much as we can, and a great tip for that. I'm also interested in positive psychology and positive aging, but VIA, I'm going to put that in. Oh, thank you. Somebody already put it. Wish, outcome, obstacle, and plan. Oh, wonderful. I wonder if you've used that. I've used it in some stuff. It's a lot of fun. So I'm going to put in the chat so that everyone should be able to see it. The VIA character strengths index, and it's a lot of fun. You need an email to use it, but then you can do it for yourselves first. Reaffirm yourself, reaffirm your strengths, and then go out and reach to other people and find their strengths as well. And we want to focus on voice and choice. And I thank you so much, Kati, for including that link in the chat. Any other strategies that you use? I'm going to, let's see. We're going to do a quick case study. This is Selena. She's 64. She's lived in her apartment for over 20 years. She lives with bipolar and diabetes, and she has strong ties to her neighbors, her faith community. And recently she started having more challenges at home, like falling, forgetting to take her medications, and not leaving her apartment. So looking at this, and I always give these kind of things, and I think, okay, first look at the strengths, because, I'm a trained social worker. I did social work for a while. I also had to really look at what were the challenges, but what are the strengths in this situation? Think about what are some of the strengths that you see in Selena? Drop that in the chat. She's lived alone for a long time, 20 years, stable housing, right? That's really, really amazing, right? Awesome. She also has some social support from neighbors. Wonderful. She's also used her medications as a tool. She has relationships with people. And one more I'm going to add is she has a relationship with her faith community, which as we age and as we experience a lot of losses and transitions, spiritual connections are really, really, really important, which is a whole nother webinar, which we're not going to talk about today, other than to say that we need to be doing more to talk to people about their spiritual connections and meaning and purpose. Any strategies that you might use to support Selena's recovery? Yeah, more examples of her strengths: ties with the community, independent skills. And some of the strategies that we might use would be goal setting. We might use motivational interviewing. She definitely needs a fall like risk assessment, right? Sugar levels in a UTI. Woohoo! You all are awesome. Fall risk assessment. A situational assessment, like what's going on at home. So great job, everybody. The pros and cons of medications and health beliefs. Very nice. Very nice. I would want all of you. I'm going to hire all of you to manage my my aging self, should I need it. Follow up by medical provider. Absolutely. And what are some of the goals that you would expect that Selena would have? I'm going to skip that one. I think we all know she'd want to stay in her own apartment. Um, let's move on to a little bit of recovery, because I think that's really at the element of this. And it's really something that's so important because that ageism can kind of influence us a little bit. Are people able to recover who are aging with mental health conditions? I'm putting out a saucy question there, but I suspect that you and I would all agree that yes, in fact, they can recover. And I see some additional goals that independence, maintaining lifestyle would be goals. A 1 day at a time list. Oh, I love that. I've not heard of that before. Wonderful. So let's talk about recovery a little bit. Oh, wonderful. I like that question. How can I help you get back on track? Wonderful. It's really important. Recovery is really important. It's living well with a diagnosis. It's not defining yourself as a patient or as a ism or ick or whatever. It's, helping someone really live beyond their illness. It's also relational, connecting to other people, as we talked about. Social isolation is so dangerous for folks. It's also very, very personal. How people define recovery is different for every single person, right? It might be for us in our mental health settings that we want the person to, the patient, client goal is to keep their housing, right? That may be their goal. It may not be their goal. So we really need to talk to the person, ask open-ended questions, sit with them, spend time talking with them to really understand what getting back to themselves or getting back on track might look like for them and what do they want to get back to. It's also about new meaning and purpose, which I think is so important for older adults in particular, because the sense of meaning and purpose becomes stronger as we get older, as we sort of face these losses and transitions, and we get to sort of the point at which that some people are facing catastrophic health conditions. They may experience end of life conditions. So we need to be helping people think about meaning and purpose at every stage of life, but particularly for people who are aging, and helping them really connect to the community. I see a question: recovery versus maintenance stage. Now, I see the stages of change in your question, the trans-theoretical model of change by Prochaska and DiClemente. That's really lovely. And I have to think of, that's kind of a deep philosophical question, which I love these questions, and I will now be thinking about for the next few days, and I might have to get back to you next week on that bit. But for now, we're just talking about what is recovery for an individual. So thank you for the question. And I have noted it and I appreciate it. Some of the things that do support recovery, I think we all know these things. A lot of research has been done on hope. How do we help someone develop hope? And as many of you know, living with major depression really affects our ability to feel hopeful. People who are living with schizophrenia often experience this sort of depression-like thing as they get older, which also impacts hope. For people living with bipolar disorder who go through depressive episodes, they may really be challenged by hope. So I think hope as an intervention is really, really, really important. And it relies on us a lot of times to help people sort of be that hope holder of the light for people when they're really struggling. By looking at growth. Very nice. I like that. Yes, looking at growth, looking at past successes, looking at strengths. Um, there's a great, this is an aside, but there's a great researcher in North Carolina who talks about post-traumatic growth. Like, what do we do after a really difficult experience? Some of us grow and learn and have a richer sense of purpose in life than before that. So something else to consider, because I know that many of the older adults experience a number of catastrophic challenges. Also, education, that hope recovery, living a good life is possible. And I think peers are a great example, bringing in that example, and strengths and that growth potential. Yep. Yep. So, anyone want to throw out some thoughts about what recovery might mean for people aging with mental health conditions? Any thoughts? I put two people, there's a guy holding a bike, and a lady walking next to them. So I was thinking about that as recovery, but oh, nice. Okay. Being able to independently manage medication. Okay. Thinking about hopes and dreams. So symptom management might be someone's goal, but what else, what might recovery look like? Um, so from a psych rehab perspective, I think about this lens of hope, and how do we kind of get it, more so that this person is living beyond their symptoms, so that they're not thinking about their medications every day. They're not thinking about their diagnosis every day, a daily schedule, engaging in the community, relationships, flourishing. Great examples. And I think that medication is a tool that many people use, and that's something that they want. But it lacks that sparkle, right? That most people that I've met have not said, hey, you know what? I really want to work on my med management. It's more likely that, hey, you know what? I really want a boyfriend or a girlfriend. And it's like, okay, how do we get a boyfriend or girlfriend? Well, one challenge is that you're not getting out of bed every day. Well, you're not getting out of bed every day. What might help that? Oh, you don't take your medications every day. Well, how might taking medications be helpful for you? So it's literally helping someone see all those things and the tools that they need in order to go to the next step. Oh, yeah, satisfaction and contentment with roles, activities, relationships, able to identify life purpose or meaning. Lovely. And self-care with mind, body, soul, and social engagements. Lovely. And also looking at wellness, being involved in the community. And someone said smartly, what any person without an SMHC would want for their life: social, spiritual, financial. Absolutely. Just living that life, not experiencing discrimination due to SMHC. Yeah, definitely not experiencing discrimination, and flourishing, absolutely. So I was very simplistic. You all are being amazing. And I was so simplistic. I was like, oh, new friends, right? And that might be a goal. Work, managing health conditions, like not feeling sort of out of control. When someone has diabetes and it's not well managed, that can really impact their mood and all kinds of things. Maybe they want to live in an apartment, and I put with supports, but I don't know, that may not be a great recovery example. Having a sense of belonging in their community, and a sense of purpose each day, and respecting each person's experience. Very nice. Yeah. So Selena recovers. She goes to the healthcare provider. She gets a new dose of insulin and pill packs for medications. She's referred to aging services for an in-home assessment and gets weekly help to clean her apartment. She contacts her faith community to get extra support and invites one neighbor over for coffee. And she starts attending a program for older adults experiencing depressive symptoms. So you could see these are sort of kind of someone had a crisis, and then they got some services from aging and from mental health. So we may have to sort of be thinking like that we need to help people connect in different kinds of ways. We know there are challenges to recovery. We've got brain health. We've talked a lot about that. The thing that I, also do need to say, someone early on asked if mental health conditions were connected to Alzheimer's. I neglected to say what is linked to the development of dementia and Alzheimer's is brain injury. And I bring that up because, it may be a large brain injury, maybe, a less severe brain injury, but brain injuries are more common in people with mental health conditions, unfortunately, and people living who use substance use. So sorry about that. We also see that people who've had more of these symptoms of not being motivated or more depressed. There's also for people who have lived with bipolar a long time who have not used medications, who've had a lot of manic episodes. There's something they call it kindling effect in the brain, which causes more cognitive decline and difficulty as people age. There are also people are on these medications for a long time. So there's a lot of things that contribute to poor brain health. There is, however, great news. One thing we can encourage people to do, as I go back to what I said in the beginning, is go for walks if they can, or move in whatever way they can, because movement is really, really helpful to the brain. Also, we've talked about this. You all seem to know this quite well. The ageism and lack of hope and loss of independence it's hard for all older adults. And I think it's hard for people who are living with mental health conditions as well. And I think one thing we do have to sort of think about as people age is some of our systems of care tend to be very paternal. So it might be that, aging systems may be a little more protective. They want to keep the person safe. And that, might limit a sense of agency or a person's desire or belief that they can make changes in their life. And mental health also can sometimes be very paternalistic. It's sort of like, we know best for you. And it's, kind of an opportunity and a gift that we can offer the person to be like, hey, yourself, what are you bringing to this table? And kind of involve the person in making decisions, involve the person in the choices that they have. Even though they may not be the choices that they want, sometimes it's very powerful to know what's out there and that you're involved and have a seat at the table of your own life, right? We've got the silos of care that we've talked about, and also stigma. That just the impact of stigma over years can be very powerful. This, some of these ideas, I'm going to talk more about some work that we did. I did with a team of amazing people, where we looked at a wellness framework for people who are living with serious mental health conditions who are aging. So that will be fun, but fun for me. I hope it'll be fun for you. Anyway, all right. So I would welcome any questions that we have. If you have any questions or comments at this phase, I had a question for you. How might you or we support recovery for people aging with mental health conditions? And I think we've kind of answered that question a bit. People are talking about respecting unique situation and not, advocating against discrimination. But I welcome any questions at this time or thoughts that you have about psychiatric rehabilitation, about people aging with mental health conditions, or how we might support them. Definitely advocating for more accessible supports. Indeed, it's really important that the supports are flexible. I think flexible services, patience, absolutely. We can support people with patience by being present and recognizing that it can take a little bit more time it's called, to ask questions, or, people may have speech difficulties due to their medications or their processing time or their illness. So having patience is really important. Also listening, maybe navigation is really important. Training. How do I identify quality training in older adults with MI? Yeah, that's a really good question. I'm gonna I've listed some resources that you can definitely check out. SAMHSA's got more and more good stuff. The National Institute on Aging has some things that are coming out. It's slow. This is still, unfortunately, not a well-known area of care. At encouraging people and asking what's changed. And how can we really collaborate with medical system? Yeah. And that happens often locally, informally. A lot of providers know, many of the folks that receive services at a certain provider may go to a certain, care provider. But there are also models for integration of care and, seeking the grants, getting the funding. Also, we can advocate for changes in reimbursement rates so that providers can spend a little more time with our colleagues and our peers that they may need, and maybe grants for transportation and things like that. So thank you so much, everyone. You all are really thinking about this. We know that attitudes really matter about aging, that in our own selves, in our systems, in our clients. The psych rehab goals, values, and principles are helpful in thinking about the kinds of services that may be promoting recovery. Mental health recovery means living that life beyond symptoms. And we can really support recovery using psych rehab. I want to give you a preview. I've dropped some hints that next week we're going to talk about best practices in psych rehab for aging. And in 2 weeks, we'll be talking about approaches to expand strengths and support challenges as people age. And the hot off the press preview, which is going to go out very soon, we're doing a learning collaborative, which I'm really excited about, in April on Mondays from 11 to 12 Eastern Standard Time. And it's going to be myself, and I'm partnering with a great organization in New York City, services, it's SPOP, and it's like services providing, oh gosh, I don't remember, SPOP. Anyway, there's 3 folks. We've got a peer provider who's an older adult who provides programming for older adults, and that he's pretty amazing. And we've got 2 folks who've designed specialized programs that focus on older adults with mental health conditions. So if you're interested in that, if your staff might be interested, we welcome that. That announcement will be coming out soon. We'll be talking about how to integrate and develop programs at your services. I also have some resources about psych rehab, about recovery, and there is also some stuff on older adults. We'll have more resources next week as well. The E4 Center from SAMHSA also has some additional information. References. Please evaluate this training. It really helps us. I look at these comments. It guides my own growth, and I really appreciate your thoughts and input. I think we will save this transcript and make it as a tag along for our production of this webinar. So all of the comments, which were so amazing, will be posted. We're going to anonymize it. We're not going to put your names, but we'll put the information to transcript up as part of the resources for this webinar. So put the link in the chat. Okay, I will do that.
Thank you, Dr. Zechner. I just shared the evaluation link in the chat. I will post it again. Let's see. So this should be there again. So thank you so much, everyone, for joining us. Next slide, please. We have so much more to share. We also have Dr. Zechner's podcast channel, Toward Wellness and Recovery. Please join us and for these episodes. They're wonderful episodes. It's titled Flourishing at Work, a Plan for Helping Professionals. And you can find these on, or find the podcast channel on Spotify, Apple Music, or Podbean. And then if you missed a webinar, you can access them by going on our website. And if you click on the products and resource catalog section, you'll be able to access all of the recordings, including the presenter slides, through our previous webinars, including this one, which, as I mentioned before, will be posted within a week of today. So just stay tuned. I'll send an email announcement with the link so that way you don't miss it. And everyone will receive a certificate of attendance for 1.5 hours and for today. Next slide, please. We welcome you to also follow us on our different social media channels, Facebook, Twitter, and LinkedIn. You can follow us on the handles that you see on the screen. And again, I just want to say thank you to Dr. Michelle Zechner. We have so many wonderful comments and feedbacks in the chat. Thank you so much for joining us. Do you have any
I just want to say, I just want to say thank you to everyone. This is the most interaction I've had in a webinar in a long time, and I'm really grateful and appreciative to all the work that you're doing. So thank you for your interest, and thank you for doing the amazing work that you're doing.
Absolutely. Thank you so much for providing a wealth of knowledge and resources on this topic. So we hopefully we'll see you all next week. We will be here at the same time. Thank you, everyone. Have a good day.